So, in the EMR, and specifically the PracticeOne EMR, now a lot of the conceptual stuff we're talking about goes across EMRs, but I'll tell you right now that PracticeOne, in my opinion, is one of the easiest to put these concepts into actuality, to make them function. In the EMR, I have multiple different ways and places I want to view the same information. So you'll recognize here, this is from the Current Meds tab on a patient's chart, where you can click to start and stop and quickly change dosages. I also need to be able to view the detail of that list. Now we're looking at the chart note index. And of course, I don't want to have to go there when I'm in the middle of my note. Now I'm in the middle of a progress note. And using a bookmark that PracticeOne has provided for us, I have all the patient's medications right here. This is actually the screen that my staff used to make little changes and notes on a medication. Now, I don't know if you can see, it's kind of small, but on the second line it says Tricor, and there's a star there. It said it was DC. So that's information that was captured 2 seconds ago when my nurse was rooming the patient. This, by the way, this screen does not flow anywhere to the other medication interfaces. It just flows out to my progress note when I print it out. So the EMR way of doing things. I have 3 levels of problem list flowing from the future to the current problem list. Same thing with medications and the past medical history. And I don't want them to be separate all the time. I want to capture them right now in my current encounter. Plus what happened today. And there's little boxes indicating that I'm going to have a plan and a history of present illness and maybe even some lab results. So we'll talk more about getting stuff into the note. We're first going to focus on getting stuff out of the note. So avoiding redundancy at the point of care. Okay. Conceptually again, I've got my current encounter with my plan. The reason I've graphicked this way is because the current encounter kind of is a vessel that captures all of the little bits of data that are themselves captured by template fields or by bookmarks. So the plan could be and is a separate entity. It's its separate field. And actually, one thing that Steve said brings this home. I think the programmers have recognized this. I may want to send a message or route an addendum just on that plan rather than on the entire note. Okay. So from my current encounter and the plan within it, I want to give a patient handout that goes directly to the patient. I also want to, of course, keep the chart up to date, so my note is up to date, and I want to alert other MDs as to what I'm doing. I may also want to send information to a lab, for instance. So let's take a look at one of our templates, actually our only template. I'll get to that, why we only have one template in the future. So at the bottom, the text points to when I want this patient to follow up. It says the text is when to return to clinic, and I've entered in there 2 months. So this is my follow-up plan. The reason I put this in a separate box will become apparent in a minute. Also, who else needs to know? Who is going to get a CC when I send this back to the referring doctor? Right now it says Dr. Glass, Camosa, Kakar, and Schoenthals are the other providers. And my lab orders for the future. I've got 2 lab orders on this patient, one for today, one for a couple weeks from now. And just notice that today I've ordered a beta-2 microglobulin. That's something easy to remember, beta-2 microglobulin, because you'll see where this shows up in the future. Okay. If I've set everything up correctly, I go to what I've clicked on here is Word Merge, and I've gone to my Word Merge documents. You've got to learn how to use Word Merge in this system. If you don't, I think there's been a couple sessions on it. My options are to send a checkout note directly from this progress note. I'm going to create a checkout note, or I can send a letter to a medical doctor. And here's what the patient gets. What this says is, here's the patient handouts, and you'll see the identified boxes at the bottom, lab tests that have been ordered for you. I'm telling the patient that today he's getting a beta-2 microglobulin. There it is, right there. And your next appointment is 2 months. I didn't have to write that anywhere else. I just put it in one box and it flowed out. And there's various doctors that will be CC'd on this note. What the other providers get. instead of me dictating a letter to them, my system automatically generates everything with the patient instructions that I've told the patient, if I want to include that in my note to the doctor. And the CCs are in red at the bottom. So again, I've tripled my output already with the system. And that's just one example of one field. Now, a caveat here that I've run into before, what if you told the patient, well, I know you don't like your cardiologist, we're going to send you to a different cardiologist, and you leave that first cardiologist in the CC box, then they're going to get a note that says the patient doesn't like you anymore. So you've got to think about your workflow. Where's information going? Where is it safe to go as you're designing your model? And then, of course, the letterhead letter that goes to the referring physician with everything I just said about the patient. So that's exactly what we did. We took information from a single encounter and put it out to 3 sources. We also are going to show you how to take problem lists and other medications and past history and insert them into the note in an automatic way. One point that Mark Anderson made yesterday that's really critical is that when you're first starting with an EMR, getting the data in, that first set of data is a huge thing to overcome. But it pays off tremendously. Some of my partners use different templates for different locations. For instance, we do dialysis. We see patients in the office just like everybody else, but then we do dialysis. And if you can input all the data about the dialysis patient the first time you see them, the next time you see them will be very easy. We see our patients every 2 weeks. The problem is it may take you 45 minutes to enter that initial set of data, and you've got 100 dialysis patients to see that day. There has to be planning for that. You can't say, doctor, stay at work today till midnight to get this done. That will not sell your system. So how did we do all this? Well, again, we started with the theory, the concepts of where information flows, and then your data model, whatever data is important to you. Where does it come from? Where does it go to? Then you need to design workflows and note template fields to capture and display the information. Decide what needs to exist at the level of a field, what can exist at the level of a whole note, what fields need to be broken into subfields. You'll see different approaches. You'll see certain templates that are click fests, millions of clicks to get through the note. Our note template is one tab, one long screen. For note display, use bookmarks and use the autofill function. Autofill is very confusing, I think, and I'll go over it a little bit, how it works. And for outputs, use merge fields and bookmarks. So here's an example of output paths, that same graphic. So for the patient handout, we're going to use the word merge with merge fields. Merge fields in your word merge document, which once you do it, it's really easy to work with. Merge fields can take in bookmarks from PracticeOne, or they can take in template field names that are not themselves bookmarks. For the notes in the chart, remember we want August, September, October notes to kind of flow together. We use the autofill function most of the time. And for information that goes out to alerting physicians, again, we're back to word merge and using bookmarks. Then I'm going to talk a little bit about the user-defined screen. Do people who are using the EHR here use the user-defined screen very much? A couple. Boy, this is the user-defined screen, the way we have it set up, does almost everything that Steve has programmed into 5.1, 5.0. If you set up your user-defined screen, you can look at one screen and know everything about the patient in about 2 seconds. When they get on the phone, Mrs. Smith calls, type her name, get your user-defined screen. You know everything. Last visit, current meds, list of problems, all the encounters she's had, all there on the user-defined screen.